Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings. Part of the previous lecture of Professor Ahmed al-Keraie about immunobiology of kidney transplantation. If you remember, and as you can see in the recordings that is present on our YouTube website of Egyptian Society of Nephrology and Transplantation, we addressed the first part, HLA typing and tissue typing. And this part, we will, inshallah, tackle the subject of immunological risk assessment, PRA and DSA, and completing all of the immunobiological risk assessment of kidney transplant donor and recipients. I would like to thank Professor Ahmed al-Keraie for his work in these two sessions and for his very, very, very fruitful presentation and to the point and informative presentation of the first part. And we expect also this part to be even better than the first one. Professor Ahmed is the professor of nephrology and medicine in Alexandria University, and is interested in kidney transplantation, genetics, and glomerular disease, and has many publications in his three fields of interest. He is one of the board members of the Egyptian Society of Nephrology and Transplantation, and one of the very active members of continuing medical education in Egypt, Arabic world, Africa, and even international world, known by his very simple, to the point, and highly scientific lecture, and ready for application in our clinical practice. So I will leave the floor to Professor Ahmed to start his lecture and come back to you again with the discussion. As I can expect from the presence of many professors in this session to be a heavy discussion and to the highly scientific one. So please start, Professor Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Many thanks, Professor Yasser, for the very nice introduction that I really does not feel that I deserve it. Bismillah, alhamdulillah, wa sallallahu ala rasulullah sallallahu alayhi wa sallam, wa ashhadu an la ilaha illallah wahdahu la sharika lahu, wa ashhadu anna Muhammadan abdullahi wa rasuluh. Well, we come back to transplant immunobiology, where we, in the first time 2 weeks ago, we started by the HLA, and at that night, we focused really not very much on the techniques of HLA typing in the labs, as much as we focused on the clinical meaning of the HLA and why we are ought to determine the HLA of each and every recipient for the kidney transplant and his donor as well. And this was a simple introduction to what we're going to discuss tonight, inshallah ta'ala, which is how to use the data from this HLA, not only to say how many matches or mismatches is between a specific recipient and his potential donor, but to perform what we call as cross-match, or if you'd like to say virtual cross-match, a PRA, or if you'd like to say calculated PRA, and DSA, which is the donor-specific antibodies. All these modalities are more relevant to the potential life of the graft and the potential success and survival of the graft, and maybe the time free of graft rejection as well, and hence the need for less immunosuppression, even more than just the absolute number of matches and mismatches between a donor and his potential, or between a recipient and his potential donor. So let's start by a simple challenging case regarding the immunogenicity. How would you grade the immunological risk of such a patient? This is a 58-year-old woman. She comes to your clinic, and she is already transplanted with a graft that functioned for 12 years, and she lost the graft because of chronic antibody-mediated rejection that we are now facing in a higher intensity and higher frequency than previously we thought. Now she had her husband as a potential donor. He is medically fit, and the CDC cytotoxic cross-match is negative. So he is negative by complement-dependent cytotoxicity. So we need to understand what that mean. But by more sensitive testing like Luminix single antigen beads, so we need to understand again what is Luminix single antigen bead. She is found to have a donor-specific anti-HLA antibody against her husband. So now there could be a real time cross-match that is negative, but a PRA, or in this situation, a single bead Luminix testing that showed that there is an antibody in the serum of this potential recipient to one allele or more that the potential donor is having on his lymphocytes, or his definitely thus his kidney. The strength of the antibody is high. It's indicated by the mean fluorescence intensity of 16,000. So we need to understand not only the meaningful of a presence of a specific DSA, but the strength of that specific DSA, and this specifically situation in the contextual of that she is negative CDC. She's concerned about the antibodies because she had the previous chronic antibody-mediated rejection. So how would you tell this lady that her immunological risk is? This is the question, and let's go for the lecture to try to answer the question together. First of all, why would a person be potentially immunized or having what we call a high PRA, or what we call it panel reactive antibody, which simply stands for an antibody that is present in the serum of a potential recipient to a panel of the antigens that is present as an HLA antigens in a number of potential donors from the population. In this essence, we have to take in consideration the common antigens and common alleles of the HLA and the CREGs and the shared epitopes and the specific type of alleles to the specific population that we are dealing with. For instance, most of the alleles that we are testing for from commercial beads that is available from the two main vendors around the globe are related to the Caucasian population more than others. So they might not present our situation completely. Definitely, there is a very high number of sharing of the alleles and antigens and the epitopes on the HLA, but again, there might not be as good as they should be. So what would cause a person to be sensitized? Sensitization can come from pregnancies, especially if they are multiple or if there is many abortions as well. Blood transfusions, again, more blood transfusion, and this even constitutes plasma transfusion and sometimes even platelet transfusion because they are not totally deprived from the antigenicity due to any concomitant antigens present on any of the associated cells. Failed graft, definitely, they causes sensitization, and there is a long debate about whether a failed graft should be nephrectomized to decrease the antigen load, or this would even increase the antigenicity because the graft might act as a sponge effect to absorb the already present antibodies in the circulation. And some authors, like in the Maryland experience, they differentiated between early failing graft where they advise for nephrectomy of any graft that fails before the first year or during the first year of transplantation versus late failing grafts after a year that can be left in place without nephrectomy. The part that might pass unnoticed, which is the bacterial and viral infections that can actually trigger immune system. And this immune system, if you remember yesterday, sorry, last session,
اتفضل يا دكتور احمد.
وقف تاني.
اتفضل.
Okay, sorry for the interruption.
كونتينيو
Okay,
دكتور احمد.
السلام
اتفضل.
عليكم ورحمة الله. Sorry for.
يعني
Okay, we'll continue. We were just saying that the bacterial and. Can you hear me?
يعني
Should I
اتفضل
proceed?
كمل. اتفضل. اوكي يا دكتور احمد. اتفضل.
Okay, so we were saying that epitopes of bacteria can share some antigenicity with some of the HLA antigenicity, and thus causing positivity in the PRA. So this can be another cause of positivity other than pregnancy and blood transfusion and failed graft that everyone knows. Autoimmune diseases, definitely they cause antibodies, but these antibodies are not specific antibodies, but they can give noise and they can give you these positive PRA or positive even cross-match in some situation, and it can be solved by doing an auto cross-match to identify whether these antibodies are related to the autoimmune disease or are specific to the HLA. After all, what we need to do is to understand whether that specific patient or recipient has any specific antibodies that are directed to the potential graft that is going to his blood or to be transplanted in his body. And this is the meaning of donor-specific antibody. People often thought that donor-specific antibody is a specific test that is to be done, and this is not true. Donor-specific antibody is not a peculiar test. It is rather analysis of the total sum of antibodies of a patient that can be detected by the panel-reactive antibody among other methodologies like the Luminix and single antigen bead, and then comparing these antibody repertoire or profile against the potential donor to tell whether or not the patient has specific antibodies toward this specific donor. So transfer of intact white cells, as I've told you, which can occur due to many situations, and even transfer of viable tissues like heart valves, definitely not mechanical valve rather than prosthetic valve. And there are even some other factors that can cause in vitro positivity with antibodies like a PRA, but in vivo they are not positive, and this can occur due to denatured protein that can occur during the processing, and this can give you some false positive results. So these are the main causes of sensitization that can be detected by a PRA or even a positive cross-match. To start with, our talk tonight, we'll try to understand what's the PRA, what's the cross-match, and what's the virtual cross-match, and how to screen. And these 2 points are very closely related. They are almost 1 point. And then the anti-HLA antibody significance. These next 2 points are almost, again, very related, which is the preformed DSA that's to be tested beforehand, before the transplant, and find that there are some donor-specific antigen or antibodies, versus a de novo DSA. That is a patient who were not sensitized and he carry no specific antibody to his donor, and then later on he developed. And what is the difference between both two? If time allows, 2 words about non-HLA antibodies. So a PRA is a panel of antigen from multiple donor cells from the population. And this is the PRA. And we have to mention here the calculated PRA as well. The difference between the PRA and the calculated PRA, that in the PRA, this is a lab test where you do the test against the beads that covers the antigen that covers the bead that you are testing by the vendor that gives you those beads. And these are a relatively small number of beads, whatever they are. The calculated PRA is, on the other hand, a PRA that is virtually calculated against a big number of the antigenicity of the population, mounting up to maybe 12,000 persons with different PRA from the data system, like the UNIS data, for example, and others. So it's the difference between the PRA and cross-match is that cross-match is mixing with a specific donor, whereas PRA is sensitivity to a panel of donors, not a specific person. It estimates the likelihood that a person would have an antibody to a cohort of donors from the population. So simply, the higher a person having a PRA, the less likely that he would find a suitable donor. If you have a PRA of 80%, for example, so you only need a 20%, not 20% of the persons, a 20% of the HLA in the population to try to find out of them a suitable donor, because the other 80% you will be already sensitized to. That's why this makes a suitability or a transplantability of a person is very remote. And definitely it gauges the immune activity, and the antibodies that are or can be detected by the PRA or other tests can be classified crudely according to the type of antibody, whether these are HLA class 1 or HLA class 2 antibody, or even non-HLA antibody. So you can have a PRA for class 1, which will be presented by a number or a percentage of antibodies, let's say 40% class 1, and another number for the class 2 antibody. Now you know that class 1 is almost like 20,000 allele in the American Histocompatibility Association nomenclature, and class 2 is more than 8,000 alleles so far. And non-HLA antibody as well, which we will come to at the end. On the other hand, these antibodies can be classified as allo-antibody or auto-antibody, because if they are auto-antibody, they are of no major significance to the transplant operation and process. Again, and this is a very important point, donor-specific or donor non-specific antibody, and this is the DSA. And the importance of identifying this is that because people still mix this up. If you have a patient who is sensitized 94% for the class 1 PRA and 90% for class 2 PRA. This is a very high risk, very, very, very high risk transplantation. It's almost obsolete. But if the donor to this specific patient is among the 6% that the patient has no antibodies for in class 1, and among the 10% that the patient has no antibodies for in class 2, so there is no DSA in spite of the very high PRA. This carries the patient from the highest level of immune sensitization to the nadir of the immune risk for transplantation. So it is all about the specificity of the antibodies. That's to say, about the donor-specific antibody rather than the whole number of PRA. Although the more the patient is sensitized with a higher level of PRA, even if not donor-specific, the more likely that he has an active immune system, so the more likely that he would need higher level of immunosuppression. But definitely, it is never a contraindication, nor relative, nor absolute for transplantation if there's no DSA. PRA class 1 versus class 2 differs because, as you know, the presentation of class 1 HLA antigen is only is both on T and B cells, whereas class 2 only presents on B cells. So if you have, for example, a positive T and B cell BRA, this is definitely for class 1, plus or minus it might be for class 2. If you have only for B cell and no T cell, so this is definitely for class 2, and mostly there is no for class 1. And if you have negative, so this is the perfect situation. You don't have antibodies for either class 1 or class 2. And if you have positive on T cell, while negative on B cell, so probably this is a non-HLA, probably is a non-HLA, because if it is class 1, it should be present on B as well, not only on T cell. So this classification is important to understand the result when you get it for the PRA. So understanding what is a PRA, let's go in depth to understand how to screen for and what it really is the cross-match and the visual cross-match in this situation. These are the methodologies for detection of antibodies, anti-HLA antibody. And these are broadly classified into cell-based methodology and solid phase assays. And it's simple. Cell-based methodology is simply you use cell and you look for that cell, whether it is lysed and dead, so it gives you an indicator that it is dead cell, so there is an antigen antibody reaction because it did kill the cell. On the other hand, on a solid phase assay, you don't use cell, you use a solid phase like micropipette or beads, microplate or beads, and you coat these beads or the microplate by antigens. And then you put the antibody and you do your wash and you look for a revealing methodology to tell you whether the antigen antibody reaction took place, so this is positive, or it didn't take place, so this is a negative. So the cell-based assay can be the complement-dependent cytotoxicity, so it is complement-dependent, so a complement would be added, and it is cytotoxicity with lysosacell, or a CDC cross-match with augmentation. And the augmentation by the AHG is a method to increase the sensitivity. Or it could be a flow cross-match, because the flow cross-match is again cell, although it is from just a small beam that one cell can pass, but it is a cell. It is a cell that can pass through the whole of the apparatus, and the beam can tell you whether there is an antigen-antibody reaction on fluorescence or not. The solid phase assay, on the other hand, can be ELISA or flow PRA, which is like the PRA or the panel-reactive antibody, which is exactly like the flow cross-match, but instead of using the donor cells, you use the beads that is covered by a multitude of antigen. That's why it is a solid phase, not a cell-based. And the other one is the Luminix. And the Luminix use what we call a single antigen bead and a double beam pathway. We'll come to this later, not to complicate the methodologies. That is not of major concern to us, all in one setting. Again, the solid phase assay is the virtual cross-match. And as we've mentioned, that the calculated PRA is not a specific test, rather than it is a calculation of the PRA against the HLA of the patient. This is again of the donor, I mean. This is again the virtual cross-match, which is simply not doing a cross-match by any of these means, but simply calculate the PRA of the patient and try to extrapolate from this what type of antibodies specific to each allele that he carries. If you have a patient that had any of these alleles, like in the example that we gave early on, she had a donor-specific antigen to her husband. So this lady, in spite of having a negative CDC cross-match, she is considered positive virtual cross-match. And we'll come to that later on. So again, just to remind you, these are the techniques of anti-HLA antibody detection, whether cell-based or solid phase assay, with the different methodologies. The main aim is to find out whether a specific person is sensitized pre-hand for a potential transplant or not. If we go to understand this in more depth, these are the cell-based assay. As you can see, the donor lymphocyte plus the complement plus fluorescent conjugated anti-human globulin, the AHG, to augment, and the serum from the patient that carries or do not carry the antibodies. And if there is a positivity here, this will be positive with this, with the complement fixing technique. The CDC cross-match will occur and the cell will be lysed, and the fluorescence conjugated anti-human globulin will give you the positivity in the form of lysed cells. These are cell-based, whether by flow cytometry or by CDC. On the other hand, the solid phase, you have either microplate, which is like ELISA in any ELISA technique, or you have a bead, and the bead is covered by a specific antigen. If this specific antigen is many antigens on each bead, that's to say we have 10 beads, each bead is painted in 10 colors. So if an antigen-antibody reaction took place, you are not able to tell which color specific is this antigen-antibody reaction. It could be for the red or for the blue or for the green, or on other hand, it could be for HLA B27 or B15 or B7 or whatever. So you cannot tell, but you can tell it is positive for this group. If this, and this is the PRA, if this bead is single bead for each single antigen, and hence you would need a huge number of beads and the cost would be much more, So if you have positivity, you would have very specific positivity with very more or less quantification to that positivity. That is a single antigen bead technique, or what we call Luminix. And both are solid phase assay. Again, you do the fluorescence conjugated anti-human globulin, and you see the result at the end. So this is how we do this. Why the cross match is important? This comes back to Terazaki, and this was maybe in 1964, where he first, when they transplanted in 1954 a twin, and the twin transplanted at that time, because they were identical twin, they got a very excellent graft, but later on, many grafts have failed. And that's why Paul Terazaki put forward the concept that there are antibodies that attack the graft, and they started to do this CDC, and they found that if you have a positive CDC before the transplantation, you would have most of your graft failing, while if you have a negative CDC before transplantation, you would have most of your graft functioning, as you can see. Okay, so this was the concept of having this CDC, but be conscious to the point that T-cell cross-match by CDC is an absolute contraindication to transplant, because this means that there is antibodies already performed against class 1, while a B-cell cross-match is a relative contraindication. You don't take that very lightly and not take it very seriously as well. This could be a specific contraindication if it is a retransplant. So you have to reconsider that this can be really against class 2, or even if the patient have a negative autocross match. And what is meant by negative autocross match? It means that you simply do the CDC cross match between the patient serum and his own lymphocytes, not to take the lymphocyte from a donor or a potential donor. You take the patient serum and the patient own lymphocytes. And if CDC cytotoxicity occurred, so these are autoantibodies, which in this essence has no meaning for the transplant outcome. And this is how cross-match is being read on a CDC plate. This is intensity 1, where you almost have all the cells non-lysed and normal. This is intensity like 4, where you have a big number of cells is already lysed, and they are fluorescent by the augmentation by HG now. And this is intensity 8, which means that all cells are lysed. And this is how it is interpreted. If you have a dead cell less than 10, this is considered negative, and the score is 1. If you have a 10 to 20% dead cell, this is a doubtful positive. And if it is 4, it's a weak positive. And this is 20 to 40% of the cells in the plate are dead. And this definitely is to be read by a microscope. And if it is 6, it's a 3 plus, 40 to 80%, and this is positive. And if it is 8, it is strongly positive. So this is the scoring of the complement-dependent cytotoxicity assay. And it should be reported in the degree of dilution to understand how positive it is, not just the positive and negative. But there are pitfalls for the CDC. A false positive cross-match can occur as a lab error, or it can skip from the next well. That's to say, over spilling from a well to the other well. So it gives you positivity for 2 wells, while the right thing is a positivity in 1 well only. Or it could be an autoantibody, and you can overcome this by an auto cross-match. On the other hand, the false negative cross-match can occur due to technical error or to low titer of antibody, although we consider always that a negative CDC cross-match, specifically if it is an augmented one, is a very good negative, that you would take it as for granted. Things are okay. Again, dealing with sensitivity, you can enhance the sensitivity of CDC by many methods like the AG augmentation or the Amos 3 wash and the modified Amos 1 wash, which is you would do wash by saline in 3 steps, and then you put your technique. It's a technical way, and the AHG for T and B cell, and definitely the flow cytometry, which is more sensitive even than the CDC cross-match. And this is the way a CDC cross-match is done: the anti-Chiari antibody, the complement fixing, and the lyse of the cell by the membrane attack complex, and the dye would enter the cell and you can see it. And the enhanced cytotoxicity using the AHG augmentation to have a better quality for the sensitivity. Whereas the flow cytometry, you can see that the cell with the AHG would pass through the flow cytometer and to be read by through the flow cytometer to be read in a single cell by a single cell, and to give you the amount of positivity. Definitely the CDC is the first one to be available. It's cheap and it gives you rapid test, but it has a low specificity. That's why it is used for screening. Definitely the flow cytometry is more sensitive, and it gives you can gives you a false positive test, and it is the current standard for use. And we've just mentioned that it's used by doing incubation of the patient's sera with the donor lymphocyte and pass them through a gated flow chrome conjugated with AHG, and they measure the surface fluorescence of the lymphocytes, and this is independent of complement fixation. So if you're looking for a complement fixing antibodies, flow cytometry might not help in this situation. Flow cytometry cross-match in positive T cell is considered in some centers as a contraindication to transplant. In others, if it is CDC negative and flow cytometry positive, they consider this is some sort of hypersensitive. They consider it high risk, but not an absolute contraindication. Closer monitor and maybe desensitization. One point to be mentioned with rituximab, if you're desensitizing a patient and you're giving him rituximab beforehand, rituximab would turn a flow cytometry cross-match positive, even if there is no cross positivity between the donor and the recipient. So this is very important. This is not the case with the Gazyva. The newer version of the total human anti-CD20, the humanized one, not the chimeric one. So what they do is you do a final cross-match before the rituximab, or you can use a pronase treating for the to remove the CD20 from the B cell to avoid the false positive cross-match. Okay. This is the flow cytometry, and using moving from the flow cytometry to the PRA. And as we mentioned, PRA or panel reactive antibody is simply substituting the lymphocytes of the donor by many beads that carry many antigens, and hence it is not a cross match. It still uses the technique of flow cytometry, but it is a solid phase rather than a cell-based assay. And the PRA flow cytometry, you don't have a single bead for a single antigen. You have one bead for many antigen. That's why it is not a single antigen bead assay. The solid phase assay has increased sensitivity and specificity. They can detect the keraie or the cross-reactive antigens, determining immunological risk. They can do a careful cross-match, and definitely they give you higher priority in organ allocation, specifically when you use the PRA to determine the patient's sensitization. ELISA is another way that can use a microplate instead of the wells, but then you don't read them by flow cytometer, you read them by ELISA reader, where many automated ELISA readers are available now, and they can give you a quantification of the percentage of the antibody among the reactions that occurs in the microplate, which is again a solid phase assay. Luminix, on the other hand, is the single antigen bead, where you do the antigenicity detection in bead by bead. Each bead represents one of the HLA antigens. So you can simply have a good number of highly specific antigen or antibody reaction. And definitely it's more specific, and the result is represented in grades, whether weak, moderate, or strong, based on the detection of the amount of fluorescence that comes out from the beads that had a positive reaction. And this is the how we measure the intensity of the reaction. This is the mean fluorescence intensity. We've just said that whether you use flow cytometry, BRA, or you use a single antigen bead, you have fluorescence that emits from the bead that is positive for a reaction. And the intensity of that fluorescence represents how much the antigen antibody reaction was. So this is how it is read. A very weak reaction with the mean fluorescence intensity of less than 1,000 is considered nothing. A low risk is a 1,000 to 2,000 mean fluorescence intensity. Definitely this is per bead, and you can have it for many beads with an MFI for 10, 20, 30 beads, according to as much as the number. So to read a PRA report, you would first read how much in the class 1, for example, 39% class 1. That's to say that person is sensitized to 39% of the antigen alleles in class 1. But these specificities are to be listed down, A1, A3, A5, B7, B27, whatever. And for each one of these, how much is the mean fluorescence intensity? So you read it in two ways. How much is the total value of sensitization, and how much is the specific allele sensitivity. If a specific allele is less than 1,000, it's very weak. 1 to 2,000 is low risk. More than 2,000 up to 8,500 is a moderate risk. And if it is above 8,500, it's a high risk. If you recall from the other lecture 2 weeks ago, we said that we adopted in the Egyptian guidelines the sensitivity index, or the RIS, which is the index of sensitivity calculated by the number of alleles that got an MFI more than 2,000. You would give than 2,000, you have 2,000 to 5,000, you would give that 5 points, and more than 5,000 till 10,000, you would give that 10 points. And a total of 17 points is considered high risk for transplantation. Previously, they said that if you have an MFI of more than 1,000, you go ahead but notify your surgeon that you have relatively high risk. If it's more than 3,000, they used to exclude from the operation. But this is now is a controversial point. Again, the antigenicity can be due to IgG or IgM antibody, and you can use the DTT or the dithiotritol treated serum to just destroy the IgM, which is a noise that we don't need. And if it is a DDT negative, so this is an IgM after treating by DTT, this is an IgM, which does not mean too much for us. But if it's after treating by DTT still positive, so this is definitely an IgG, which is the main concern in HLA sensitization. If you go for the advantage of Luminix as a single antigen bead, it's simply more precise identification of the antibody. It gives you each allele by itself and use most of the common alleles in the whole class A and class B, class 2, I mean class 1 and class 2, A, B, C, and DRB1, DRB3 and 4 and 5, and DQA1 and DQB1, DBA1, DPB1, and as you know, that every person should have at least 2 of the alleles of the DRB chain, beta chain 1, 3, or 1, 4, or 1, 5, or 3, 4, and so on. And they should have 2 also from the DQ and DP. And DQ and DP, either they have an alpha or beta chain in either DQ or DP. And you know now that DQ is important in the sensitization, and the presence of antibodies against DQ is highly associated with antibody-mediated rejection, specifically even the chronic one. It is a semi-quantitative, and it enables determination of the antibody level by high, moderate, or low. And it is sensitive, it is rapid, and it is used in the virtual cross-match as we've just mentioned. So the virtual cross-match, again, is you don't need to have, it's of very major importance in the disease donation program, because you don't go for a potential disease donor and take a sample of his blood and wait till to do a real-time cross-match by flow or by CDC and wait for the result to be taken by next day or the day after, and definitely you would lose the graft. So a virtual cross-match in this situation is just you take the HLA typing of that specific disease donor that you already know because he is already enlisted as a potential donor, and you know what are the single antigen bead or the Luminix of your recipient and what type of antibody does he specifically have. So going to that point, and please take a big notice of what I'm saying right now. If you have a patient who is by Luminix 0 class 1, 0 class 2, no antigenicity in class 1 and in class 2, so this patient is virtually cross-matched 0 against any donor. This is very important because we really waste time and money in doing maybe unwanted tests. Of course, we do the cross-match again, and we do it preoperatively to be sure that nothing have changed. But if there is a time lapse, if there is no time lapse, there could be no added benefit of doing a physical cross-match against a specific recipient in this situation. And you can extrapolate this to as much as amount of PRA the patient have, as long as there is no DSA among them. I hope this point is set clear. Definitely, there are other important points, which is, for example, non-HLA specific antibodies like the MICA and the angiotensin receptors and others. And there are some technical limitations. That's why you don't take all. The technical limitations are always related to the standardization and the type of the antigens that are mainly coming from the Caucasian and the prozone effect and some misleading data and the variation between the lot to lot and the vendor-specific variation. This is the virtual cross-match that we have just mentioned, and thus we now understand what is PRA, what is a cross-match by the CDC or the flow cytometry, and what is the cross-match. And this is again the revision of all of them with how the methodology of being done using the complement or the AHG or using the solid phase assay by the beads or by the flow cytometer measuring the MFI or by the dual beam laser to detect the bead from one side and the antigenicity on the bead or the fluorescence of the bead from the other side. And definitely the solid phase assay are better than the cell-based assay, as we mentioned earlier. Although screening for non-HLA antibody is now being used in this solid phase assay, but whether to do it as a screening or not is still a questionable point. How to grade the immunological risk? After we understood how to do it, how to grade it, we would grade it in the essence of the occurrence of hyperacute rejection, which should be obsolete now. And this only occurs if you have a T-cell CDC IgG positive cross-match. And this is a total contraindication for transplantation. No one can transplant against a T-cell CDC cross-match. The acute humoral rejection or cellular rejection can occur with the B-cell CDC IgG, that is to say DDT treated, or T-cell flow IgG or B-cell flow IgG. The flow is more sensitive and detects less amount of antibody. It does not cause hyperacute, but can cause acute. The low-risk patient are the ELISA antibody detection, the Luminix antibody detection. The ELISA HLA specific is definitely a little bit higher. The Luminix HLA specific again, and the single antigen bead by Luminix. So what are the significance of these anti-HLA antibody after we came to know how we detect them? This slide we have shown in the previous lecture as well, which is a continuum of antibody-mediated rejection from the early acute to the chronic active antibody-mediated rejection, going through the subclinical or the smoldering one and the acute in between. Definitely the clinical setting is well known, but here I'm concerned with the DSA, even the histology and the C4D staining by immunohistochemistry, which is even in this situation, it's better than the immunofluorescence. The serum DSA is high, definitely, in the early acute and the positive cross-match is there. And in the acute ABMR, the DSA is again high, where in the smoldering or subclinical, it is low to mid-range. And in the chronic active, again, it is low to mid-range. So you can still detect it, and you should be aware with the clinical situation and the other histopathological and C4D positivity, maybe can, as well the gene transcripts that can be added in here to tell whether this is significant or insignificant antibody-mediated rejection. Okay, should we monitor DSA and how we would monitor this? And is it differing to does it differ to monitor them for a patient who already has a DSA pre-transplant or a patient who does not have a DSA pre-transplant? That's to say, to look for a pre-existing versus a de novo donor-specific antigen. This study showed that those patients who exhibited positive flow cytometric cross-match at the time of transplant, they are classified into three quartiles. 2/3 of these patients, they have a complete elimination of the flow cytometric cross-match and the solid phase assay reaction within a year. And these had few adverse events with a 95% 3 years graft survival. So if you have a positive flow cytometric cross-match, definitely with a negative CDC cross-match, and you have some solid phase assay reaction, you can turn this all negative within a year after being treated by the induction and the immunosuppression. Obviously, this is the cause of turning a positive one to negative. The remaining third, which is not a small amount of the patient, failed to eliminate the flow cytometric cross-match or the solid phase reaction against HLA class 1 or 2. And these have inferior graft survival down to 67% with loss of the graft due to chronic rejection. So this is to be taken seriously because 1/3 of your patient would lose their graft. Okay, so should we monitor DSA after transplantation or not? And does it differ if you have a low level of DSA using a single antigen flow beads like the Numinix, where it is not detected by CDC? And would you monitor or not those types? And would you look for other types of antibodies, like, for example, non-HLA antibody? These are the donor-specific allele activity based on combining different cross-match techniques. If you have a high level of DSA by CDC cytotoxicity cross-match positivity, so this is considered the highest level. If you have a CDC cross-match negative and flow cytometry cross-match positive, this is considered low-level DSA. If currently all are negative assay, but historical serum is positive for DSA, so this is considered is a historical DSA. What it meant by historical DSA? That the patient has a specific antibody to his specific donor in the past, although it is now not present. But this is of value because in the memory cell, these can be activated at any moment by specific etiologies, or, for example, by the decrease of the immunosuppression, whether intentionally by physician or by the patient non-compliance, and this can allow this historical DSA to reappear, for example. On the other hand, if it is non-donor specified, where you have anti-HLA body detected, but not donor specific, the example that we gave many times before, this is low risk of immunization. And the non-sensitized is those who have no anti-HLA antibody at all. So this is the stratifying of the risk according to the antibody level and the method of detection of the antibody in different type of patients. We've just mentioned that if a pre-transplant and anti-HLA DSA is negative and post-transplant is negative, you can see that the survival is best, and both antibody-mediated and T-cell mediated are at the nadir. If you have a pre-transplant negative anti-HLA DSA and the post-transplant positive DSA, the antibodies started to antibody-mediated rejection increased. No T-cell mediated rejection here, definitely. And you can have a combination in those patients. If you have a positive pre-transplant with negative post-transplant, you have a increase in the number of antibody-mediated rejection, in contrast to those who do not have initially. and the T cell mediated rejection can occur in those type as well, and combination can occur in these. If positive and positive, this is obviously the worst situation that you might face. And this is the evolution of antibody-mediated rejection from where it starts to where we get it. If you can see, we match the patient here with the rising creatinine or proteinuria, which is far, far beyond the point of start and very near to the time of graft loss. We need to catch the patient earlier. Here are the earlier inflammatory events. Pathology is more or less still normal, started to be abnormal pathology here with the de novo DSA. So de novo DSA can appear very early. And this carries a big clinical question, whether you're going to screen your potential patient, or your transplant recipient with de novo DSA or not, and how frequent you're going to do that. Then the pathological finding with the peritubular capillaritis, C4D positive or negative, then the glomerulitis, the IFTA, and the transplanted glomerulopathy. And at the very end is the clinical manifestation of the chronic antibody-mediated rejection or the acute antibody-mediated rejection, according to what you have. And these are the guidelines, although 10 years back, but they are still valid in the management of the issues with HLA and non-HLA antibodies, and classifying the patient into very high risk, where you should desensitize, a high risk with a DSA positive but cross-match negative, like our patient. And in those patients, you have to do a protocol biopsy in the first 3 months, and treatment if you have an evidence of clinical or subclinical rejection. So our patient would be transplanted with a protocol biopsy. And if there is a subclinical rejection or a DSA increase in the serum, you would start the treatment directly. If a persistent DSA and normal biopsy, increase the immunosuppression level. If DSA and biopsy are okay, so this is a low-risk patient. Intermediate risk, when only you have a historic DSA, you just monitor DSA, don't do a protocol biopsy in the first months. If it is positive, biopsy should be done, and you treat if acute rejection, or monitor each year if the biopsy is okay, and then if the DSA turned to be negative, this is a low risk. On the other hand, a patient who is unsensitized and first transplant, you might monitor for the DSA every 3 to 12 months after transplantation. And whenever you're trying minimization, or you're afraid from a non-compliance, or you're afraid from a graft, or you have a graft dysfunction. If DSA is positive, do a biopsy and treat if acute rejection is there. Monitor in 1 year if biopsy is negative, but there is high incidence of increasing sensitivity. And definitely if the DSA is negative, you don't need to have a monitor for the DSA. And this is how you would do. You would store a serum each year, 1 serum from the patient each year. You can come and look back whether the DSA had started that time or not. Now we come near to the end of this, and whether a preformed DSA versus a de novo DSA differs. And this is a number of trials that look at the impact of single antigen bead detecting a pre-existing DSA on the kidney transplant outcome. These are a multitude of trials, as you can see, and they are, if they are to be updated, you will find another lot of them. Many of them have found increase in the antibody-mediated rejection. Few have found no changes. Some did not put, and some only found the increase in antibody-mediated rejection if there is increase in the if the DSA was class 1. Other report that with the class 2 DSA. On the other hand, the graft survival was definitely inferior with most of these patients who had that single antigen bead specific DSA in those patients. On the other hand, the non-HLA antibody, which are antibodies not related to the HLA, but to other, and they cause as well a challenge of antibody-mediated rejection, and we'll come to them in brief at the end. They, with the specificity of the ECA or the MICA or the AT1R or the APO1, again, most of these, maybe the ligand or PCAN3 and others, they found as well some increase in the incidence of acute antibody-mediated rejection, and the graft survival was inferior in some of them and not detected in the others. A preformed DSA definitely affect the graft survival. You can see how much patient with HLA DSA antibody-mediated rejection, they have the worst survival. If you have a DSA but no antibody-mediated rejection, you are in the midway. If you don't have DSA, this is the best survival over years after transplant, up to 7 or 8 years. And again, the incidence of antibody-mediated rejection is higher when you have a preformed DSA. At 1 year, all subclinical antibody-mediated rejection had a DSA detectable. Okay, so antibody-mediated rejection, even in the subclinical form, had a higher level of DSA. Again, whether you detect this DSA by flow cytometry cross-match and the intensity of that flow cytometry cross-match with augmentation or without augmentation, and if you have negative flow cytometry cross-match. On the other panel, you have DSA, so this is a virtual cross-match with a cell-based assay, and this is a DSA, sorry, this is a real cross-match, and this is a DSA, which is considered as a virtual cross-match. If you have no DSA, you have the best survival, exactly like if you have a negative cross-match. If you have a class 1 or 2 DSA less than 5,000, so you have a survival that is equivalent to this of flow cytometry cross-match less than 300. And if you have more than 10,000 or 5,000 to 10,000 and more than 10,000 mean fluorescence intensity, you would have worse prognosis and survival of the graft, exactly like if you have a positive cross-match with AHD augmentation. So this is about the impact of preformed DSA on the graft outcome. And the de novo DSA is a patient that had no DSA prior to transplant, but he acquired donor-specific antibody after being transplanted, and this usually would lead to lower graft survival, poor transplant function, and proteinuria. And this may be the major cause for chronic antibody-mediated rejection. And to cut a long story short, it leads to loss of the graft over a couple of years. It causes increased renal function and proteinuria. It's mainly related to non-adherence or physician-mediated decrease of the level of immune or the immunosuppressive agents, because of they thought that the graft is now good and quiescent, as well as the patient himself. So, for example, decreasing the MMF dose from 2 gram to 1.5 gram, or from 1.5 gram to 1 gram if the patient is on Prograf, or decreasing the Prograf level to below 5. Previously 4 to 7, recently 5 to 8, the trough level. So if you go down to 4 or less, even in some situation, this might be associated with a new appearance of de novo DSA. If you're going to do so in a very well-matched patient who is a very low immune risk, please do DSA on regular interval as a screening to avoid having a subclinical rejection that might culminate into chronic antibody-mediated rejection. This is the story, and you would do the monitoring of de novo DSA because it can predict the development of chronic antibody-mediated rejection. And this study proven that monitoring this properly because of non-adherence leads to not only chronic antibody-mediated rejection, but also chronic T-cell mediated rejection, and that non-adherence was the major risk factor for loss of the graft versus those who were adherent at the end of 12 years even. This is a model of alloimmune-mediated graft loss. Previously, what was called as a CNI toxicity, now it's not carrying a lot of care. Donor age is an important issue all through the way. The type of the donor in deceased donor, whether brain death with a degraded graft function, ischemia, reperfusion, injury, and how this can activate an early TCMR, and the smoldering TCMR that can continue when you thought that you already overcome it and you do not follow closely. And the HLA mismatches, specifically in class 2, as we mentioned in the previous lecture, can give you a subclinical and then move to clinical with a de novo DSA that can cause an acute antibody-mediated rejection. Again, this can be smoldering and can lead to chronic transplant glomerulopathy and eventually culminated into graft loss. Another trial that showed the relative importance between de novo versus the pre-existing DSA. And as you can see that with de novo DSA, the onset of antibody-mediated rejection is a bit later because you need more time to perform the donor-specific antigen versus the early onset of antibody-mediated rejection in the pre-existing DSA. But with time, you again have a cumulative incidence of ABMR over the years that is of high magnitude as well. On the other hand, the graft survival in pre-existing DSA, as you can see, after 8 years is lower in the cases of pre-existing in the cases of de novo DSA in comparison to those with pre-existing DSA. And this is not only by the antibody-mediated rejection histological, but by the biochemical parameters, which can be measured by the transcripts and the gene transcripts that are being used nowadays and postulated to be among the criteria to diagnose the ABMR, along with the C4D and the peritubular capillaritis histologically and the DSA itself. Lastly, the non-HLA antibody can be detected by the Luminex and can be quantified by the PRA, and these can give you many number of antibodies, more even this number. They are now like more than maybe 45 or more antigen that can be detected, but the specific specific or the relative specificity of each of them and how much they help or they harm the graft is to be well elucidated yet. The most famous of them is the 81R, and in this essence we can use ARBs in this situation, anti-pre-Lecan antibodies associated with vascular rejection and the chronic allograft rejection. Anti-collagen 4 is associated with chronicity-like transplant glomerulopathy. I hope that we have came to understood the take-home message. DSA level is important. whether pre-existing or de novo. It can be detected by the flow cytometry cross-match or the CDC cross-match by the cell-based assay or by the solid phase assay, which is the gold standard now, using the PRA or the calculated PRA, using the Luminex single antigen bead and the virtual cross-match, knowing the HLA of the receive of the donor and the single antigen bead and the PRA of the recipient. And definitely, if you do good matching regarding your patient and recipient, you can have a good immunogenicity outcome, and this would help to keep your graft for a longer time and avoidance of the increasing level of chronic antibody-mediated rejection as well as the chronic T-cell-mediated rejection. The surveillance for the DSA is important, but it should be tailored according to the patient situation, knowing his pre-transplant immune status and following his clinical and biopsy finding if high-risk patient. Thank you for your attention, and I'm waiting for your questions.
Thank you very much, Professor Ahmed, for this highly elegant and informative lecture as usual. It was a very interesting journey through testing pre-transplantation, immunological risk, assessing DSA, PRA, and CDC with different and flow cytometry, cross-match, how to assess, and even including important stress on points such as the effect of rituximab. Also, the difference between ELISA and flow cytometry and which is better, and how to interpret this in the view of antigens and in the view of MFI. Also, DDT, effect of DDT, what is DDT effect on the test, and the advantages of Luminex, what's Luminex and when to use, and what's the advantages of this test, and virtual cross-match, when to use, and the stress on an important point that if the cross-match is negative in all, it is the patient is not sensitized to any donor at all, and no need to proceed for further test. Should we need to monitor DSA after transplantation or not? It was an important point of this talk only. Also anti-HLA antibodies, DSA, whether de novo or performed DSA, and what is the difference and what is the effect? And lastly, the non-HLA antibody. Thank you, Professor Ahmed, for this very, very, very interesting journey. And we have a question on the chat. Shall we test as a protocol the DSA post-transplant every 6 months? From Dr. Mina Mashriqi.
Thanks for the question. Thanks Professor Yasser for the compliment. أتمنى إنه يكون يعني simplified the issue a little bit. I know we are not immunologists and not clinical pathologists, but we have to understand not only the difference between the techniques, but the potential relevance of each technique to take the proper decision. Regarding doing the DSA on regular basis for the patient post-transplant or pre-transplant, these are two different questions. I'll answer both. Pre-transplant,
yes.
If the patient is sensitized and is you're going to start a desensitization program for him, whether a chronic one using statin, using tacrolimus, using MMF on long term, whether you believe that this can help or not, or whether an acute desensitization program using plasmapheresis, using IVIG or rituximab or Gazyva. In this situation, yes, you definitely should redo the DSA. And whenever you find the DSA started to be negative with a negative virtual or flow cytometry cross-match, you can go directly for the transplantation with a very strong induction. In the post-transplant situation, I think this will have been shown in the lecture. there are specific situations where you need to monitor the DSA according to the 2013 consensus of how frequent you should monitor, each month, each 3 months, or each year, or once and then you don't do it again, according to the trajectories of the patient immunological risk before transplantation. So the table is there. I think it can help in this point.
Okay, thank you. Professor Faisal Shaheen wants to comment.
Yes, thank you very much, Professor Ahmed. Excellent talk, and as usual, we expect this to come from you. Really, you know, this advance in immunological tests is making progress of the transplant is better and better than before. So my question probably it is very, you know, very primitive question about human error in testing the cross match, especially because we have it long time back when we got someone who is negative, and then after transplant he got hyperacute rejection. Then we reversed the things and we found that he was positive. This error nowadays become less, probably because of flow cytometry or because something else. People start to be trained more, or still we could have such error again in transplantation.
Yes, Jazakallah khairan. Thanks for the compliment again. I hope that it can be useful. Regarding this point, definitely this is a nightmare, and I can put myself in your shoe, Professor Faisal, and feel the pity of having a hyperacute rejection on table, and this is a disaster mainly for the immunologists, because hyperacute rejection is definitely an immunological mistake. Yes, definitely it is much more less nowadays because of the two reasons. First reason is the automated machines like the flow cytometry cross-match and even the PRA. For example, if you have a patient who is negative PRA, so mostly you would anticipate that the cross-match would be negative, whatever method it is to be done. But if you have a patient with a very high positive PRA, you would look twice and thrice, and you might repeat the cross-match, whether by the virtual or by the flow cytometry, or you would even order for a CDC again to be sure of it. So definitely the new technologies helps in answering this point. The other point is the quality control inside the labs is a very important point. Nowadays, there are many methods of quality control that the patient, upon sampling of his blood, it is to be labeled by a barcode that would prevent the mistake of sampling, for example, because as you know, when we speak about lab errors, you would speak about sampling error, you would speak about procedural error, and you would speak about reporting errors. All these can occur. And the quality control, like quality is now invading all our aspects of our lives, and it should be one of our main missions and goals. As you know, in this is the wasiyah of the Nabi sallallahu alaihi wasallam. إن الله كتب الإحسان على كل شيء. We have to perfect everything that we do. In this point, the quality control definitely is another cause for decreasing the lab errors in this very critical point. Thanks for the point.
Thank you.
Thank you, Professor Faisal. Professor Ahmed, I have a question. Professor Ahmed, is there any difference or recommendation for different sterilization protocols according to lab results?
You mean of how the lab should report the result?
No, selection of the different desensitization protocols, medical desensitization protocols. Is there any recommendation for different results?
Definitely, this is another issue. This is a whole lecture. But to sum it up, I would say if you have a patient with a very high intensity of PRA, like 90 plus, 80 plus, 80% and 90%, and this patient definitely is not lucky enough to have a negative DSA, definitely most of these patients would have positive DSA. I would say this patient is not transplantable at all, at least in our situation. It's not transplantable at all. But if you have like 60 to 80%, and again, you have some DSA, but not of very high MFI, with a relative intensity or sensitivity index that is not too much high, definitely you would use the highest level of desensitization. And this highest level of desensitization would include, first, and even before desensitization, you can look for an alternative donor through the shuffling of the donors between different recipients, as is well known now in Saudi Arabia with Professor Faisal and Professor Khalid Mashari long time ago, and in many other countries around the world. So this would be a very nice to decrease even, not you might get a total negative DSA, or you might get a lower load of DSA through this dominance between the donors. The next move is to do a desensitization using IVIG, plasmapheresis, rituximab, or Gazyva, better even than the rituximab, and monitor the level of DSA decrease. And then you would do an induction using ATG or Campath, and definitely give the full triple immunosuppression protocol using the tacrolimus, MMF, and steroids, and you still anticipate for antibody-mediated rejection.
Any level for DSA that you shift?
No, I mean the DSA more than 17 by the RIS or RSI is a contraindication for transplantation. And 17 would mean that you have one DSA of more than 10,000 MFI, and one DSA of more than 5,000 MFI, and the third of more than 2,000 MFI. If you have 3 DSA, one is 10, one is 5, and one is 2, don't transplant these patients.
Okay. I'm taking from your speech up that you monitor DSA decreasing, and then you shift your desensitization protocol. Any level do you recommend to shift at this, or just by your clinical experience?
No, definitely. If you have no, this is related to the PRA, not the DSA. If you have a PRA less than 20%, it's of no significance. If you have a PRA of 20 to 40% with no DSA, this is just a mild increase in the immune risk, but it is not. You don't need desensitization at all. You only you can still use a non-depleting antibodies. You can induction. You can use basiliximab, for example. If you have a PRA more than 40% and no DSA, no desensitization, but go for a depleting antibody. If you have a DSA, if you have a more than 40% and more than 60% and no DSA, it's even higher level of immunosuppression that you need, but maybe an ATG with a higher dose, but still no desensitization. So desensitization is only applicable if you have donor-specific antigen in your PRA panel. If not, no need for DSA whatsoever. If you did the DSA and you have a decrease in the level of the MFI, for example, one turned totally negative, or one turned from 5,000 to 2,000, and most of them became less than 3,000, go ahead and transplant, but you're still at a higher risk of immunogenicity because of the historical DSA that your patient has.
Okay, thank you so much. Question from Dr. Ahmed Abdeljalil. He is asking, at what situation I may need an immunologist opinion regarding this test interpretation? Many thanks. And there is asking if there is any recommendation.
Sorry, I haven't got the question. Asking about of what? Of having what?
When to take the advice of immunologist into this test interpretation?
Yes.
You recommend
Wallahi, this is an excellent point. And the short answer is, in every single test, even in the simple HLA, you should interpret like we do with the clinical pathology correlation. You should have an immunoclinical correlation. You can simply interpret an HLA as a 4/6 match, while it can be 6/6 match because of the permissible mismatches that is there, for example, or because of the higher or lower resolution of the test, for example. So even at the level of HLA, you need the advice of the immunologist. But definitely, if you have any state of positive PRA more than, let's say, 40%, you need to discuss it thoroughly with the immunologist, because you might need to do an auto cross match, for example, or auto detection of the autoantibody that would decrease the PRA maybe from 40 to 30 or less, and this would transfer the patient immune status or sensitization status. This is, the PRA is not donor specific. In any case of a donor specific antibody, you should go for the immunologist and discuss each antibody separately. What do you think about this specific antibody? Why do you think she got or he got that antigenicity? It may be that you need to do an HLA for a kid of the mother that definitely wouldn't be the donor, but could be the cause of her antigenicity because of the cross reaction of the blood during the labor. Or you can test the husband while the donor would be a sister or a brother, but you still need to test the husband HLA because she might be sensitized to the husband HLA that matches with, for example, with her brother in another type of allele, for example, that is not the allele, the haplotype of the recipient. So definitely you would need to discuss with the immunologist not only the result of the lab, but the potential next move that you're going to do for further elucidation of the immune status of the recipient. Thanks for the question.
Thank you very much. And I totally agree with you that the shared decision is very important in this complicated and issues. Professor Saeed Khamis wants to comment, please.
Thank you, Professor Yasser. Thank you, Professor Keraie, for this elegant presentation as usual. My question a bit related to practical implication of this immunobiology in renal transplantation. As you mentioned, Professor Keraie, and it is known that the graft failure or previous graft failure can sensitize the patient, and you mentioned some of the notes about this issue. My question regarding shortly in algorithmic way, in your nice algorithmic way as usual, how to manage a failed renal allograft. In another meaning, what I mean, if it is early or late failure, if to make graftectomy or not. Third issue is how to manage the immunosuppressive medications, and putting in mind the issue of the graft intolerance syndrome. And thank you so much.
Thanks, Professor Said, for the nice question. Again, it's another issue with a big controversy and needs a whole lecture. But to sum it up, let's start from the end point. I wouldn't do graft nephrectomy for a patient who is transplanted 15 or 17 or 18 years ago and who lost his graft because of non-immunological causes, and he is subject to second transplant now, even if he has a high PRA. Because in this situation and in this essence, I would consider that the graft can act as have been postulated a sponge for the antibodies that is present in his serum and would trap these antibodies. So no need to take the graft out, unless definitely have a surgical cause or infected or whatever. And to this point, I would say, although having a patient, for example, on dialysis, waiting for a second transplant, and he's already on thrice weekly dialysis and maybe totally anuric, I do not recommend to stop the immunosuppression. On the contrary, I urge each and every physician and nephrologist working in the dialysis unit to continue immunosuppression in a minimal way, maybe 1 milligram of tacrolimus, maybe 1 or 2 tablets of MMF, maybe 5 milligram of prednisolone. On any account, you have to keep it for two reasons. The first reason is to prevent development of DSA, as long as the patient is intended to have a second transplant. Second reason is to prevent graft rupture or graft attack by the immune system that might lead to necrosis and hemorrhage and bleeding and infection. And I've just met 2 patients in the last 3 months suffering from the same situation because after they came to dialysis, after 12 and 15 years from transplantation, their dialysis physician told them, stop every immunosuppression because you don't need it right now. We don't do that, and we don't do it abruptly because you still have some immunogenicity in these grafts. If you come to the other end, if a patient is transplanted 3 or 4 months back and he lost his graft for a reason or another, immunological or even non-immunological, I wouldn't recommend to leave the graft. Because specifically if the patient is going to be retransplanted or preparing for a second transplant. And this was the Maryland protocol, that they do graft nephrectomy for grafts who failed within the first year. Definitely the surgeon never liked to have a graft nephrectomy, and they consider it a much worse operation than and much dangerous than doing a graft transplant or a kidney transplant itself, because of the adhesions and the fibrosis surrounding and the multiple injuries that might occur. But in this situation, I think graft nephrectomy can be justified to avoid unnecessary immunosuppression and in the meantime to avoid development of DSA. In between first year and 20 years of life, the spectrum is very big, and I think you have to tailor it per patient, per situation, whether he's going to be retransplanted or not, whether he has an active disease or not, whether he still have a residual renal function or not, whether his dialysis plan is settled and his access is there, and what was the cause of his graft loss in the first place. Is there a concomitant viral infection, BK virus, CMV virus, or whatever? This will govern your decision after all. Thanks for the question.
Thank you so much.
Thank you
so much, Professor.
Thank you, Professor Saeed, Professor Ahmed. Dr. Ahmed Abdelgir is thanking you for this very highly elegant presentation. And no more comments.
Thank you. Thanks everyone.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله
وعليكم.
وبركاته. بارك الله فيكم. عليكم السلام ورحمة الله.
شكرا جزيلا
شكرا
دكتور.
Nice
جزيلا.
having you all. بارك الله فيك. جزاكم الله خيرا. نراكم على
جزاكم
خير
الله
إن
خير
شاء
يا دكتور
الله.
احمد، الف شكر دكتور ياسر.
جزانا وإياكم. الله يبارك فيك والله يكرمك. ولا تنسوا